That as soon as you say master vagina, Differential diagnosis.
Actually, you listen to them. If they have forgotten some point, then you can raise your hand. Okay? Before the final verdict, you can raise your hand and tell what they have forgotten.
The first diagnosis will be uterocervical prolapse. Then inversion of uterus, Gardner cyst, Bartholomew cyst. Then it can be cystocele, rectocele, enterocele, urethrocoele, pedunculated fibroid.
Okay, very good. Anything we have missed? Dhananjay has recently seen a case of inguinal hernia which presented like this exactly, but under diagnosis they don't remember, it's okay. Okay? Anything else? Very important thing we have missed. Tell me what's that thing? If this patient would have presented hysterectomy also done.
Wall prolapse.
Okay? So there can be so many differential diagnoses, people get stuck at this question itself. So there can be isolated cystocele, rectocele, urethrocoele, pelvic floor, and there can be any cyst or mass. We have given a list. Only thing we have forgotten was a wall prolapse. Okay? So now my second question is that when you say that so many differential diagnoses, which is the commonest which you see in gynecology practice?
Uterocervical prolapse.
Uterovaginal prolapse. So how do you say that this mass which this patient is having is a uterine prolapse and not a polyp cyst? Do you have a question which you can ask? I have asked the patient that
Cough impulse, strain, mass increases on straining, like coughing, or when
cough impulse. What is cough impulse? Is an examination finding. You understand? You have to know what is history, what is examination, what is investigation. Okay? So patient complaining that cough and straining, it is increasing. That history is cough impulse is what you see with your eyes. Okay? So when the patient says that whenever there is episodes of increase in intra-abdominal pressure, then the mass increases. If patient is not able to answer this question, will the mass change during the course of the day? How it will change?
by the end of the day, the mass will increase in size.
Yeah, because patient is working. After resting, patient takes up, so there is a kind of diurnal variation. Patient will say that morning I don't have back, I don't have any mass, but as the day comes towards its end, the mass becomes big. Okay? So the list you gave me, list of differential diagnoses. Can you tell me what all masses will have the same thing? One uterovaginal prolapse, what other masses will have the same history?
Wall prolapse.
Wall prolapse. Why it is happening? Whenever the mass is connected somehow to the abdomen, then the abdominal pressure is being exerted there. What are the masses?
Inversion of uterus.
Inversion of uterus will not increase.
Cystocele.
Cystocele will increase. Rectocele and enterocele, all those cysts and masses will not increase. But whatever are defects in the pelvic floor, that will increase. So any hernia, this prolapse is also basically kind of, so what Dhananjay ma'am was saying just now. Recently, patient gave exactly the same history that I have mascular is increases with coughing, sneezing, and straining. And when patient said that he had one cesarean, that too was done for breech presentation. It was like this thing. So there is no childbirth-related trauma. And when we saw her, examined her, there was exactly one beautiful inguinal hernia, but that you don't tell the exam. Please. Okay? Exam there will reduce your mass, don't tell. So what is the law of exam? You talk of common things you pass? Commonly. You talk of rare things you pass? So talk of common things and then pass and on. Okay? Then what is the next question? Now you have asked so many things for the patient. So now suppose we have confirmed that it is a prolapse, uterovaginal prolapse, or some of the pelvic floor defect. Okay? So how do you know what kind of defect it is? I will give you a hint. Defect can be cystocele, enterocele, rectocele, and entire uterovaginal prolapse. So how do you divide these symptoms?
It is based on the complaints what the patient gave. Based on anterior compartment, patient
Very
gave.
good. So you have to divide it. You can also answer something, or she has told no one can tell. She is the good of the three. No? Okay. Tell what compartments are there.
Anterior compartment, then center compartment, and the the posterior compartment.
Tell me what would be the complaints of anterior compartment?
Anterior compartment, if it's early stage, mostly the symptoms will be of incontinence.
Do you tell all symptoms?
Urgency, frequency, incomplete voiding, retention of urine, burning micturition.
Chest and dryness and episodes because of retention. So all these symptoms. Let me see how well you are listening to the history. Is the history present in this patient? Yes or no? Is the history present? It is very much present. That means all of you are sleeping. Okay? So when this history is present, that means there is some kind of cystosine component also you have to think that it can have. What is the central compartment? Almost give the mic to her.
Cervix.
Central compartment has cervix and vagina. What are the complaints?
The cervix will be coming out.
History of patient. If patient is so intelligent that she can know that my cervix is coming out, then she can very well manage her prolapse.
A mass will be descending when she
Who will tell me central compartment complaints? Please tell.
dyspnea.
Dyspnea, okay. If discharge the vagina can be there and bleeding the vagina. Next is discharge. It is mostly, actually cervix if it has come out, it will get infected and bleeding is basically from one specific ulcer. Decubitus ulcer. All of you have heard this name, decubitus ulcer. So mainly there are sexual problems. Dyspnea means what? Pain. So when everything is relaxed, pain is little less likely, but difficulty in sexual activity can be there, bleeding for vagina and discharge for vagina can be there, which is mainly because of decubitus ulcer, which happens in the usually very good, most dependent part of the prolapsed mass. Okay. Then posterior compartment complaints.
Constipation,
Hmm.
finger splitting, digital evaluation.
Okay. Enough. This patient had it or not? He had? You are not listening at all. Huh? You can't tell master, give them chocolates. Give them these 3 little chocolates, okay? Okay. So you have to listen to history. So patient did not. So what we are expecting? She has discharged, bleeding, these complaints she had. So one thing from history is some kind of mass for vagina, and what we are thinking that it can be some kind of cystosine. Okay? This is what we understand. And history, anything significant is there?
Incomplete voiding.
No, that is that. Any other history? History of present pregnancy, actually presenting complaint. Other than that, present history, other than that, anything you thought which is good in favor or against in this patient?
Obstetric history. Patient at
So
first
what is in favor? So
vacuum delivery.
vacuum
Delivery.
So one thing you remember, if I ask you a simple question, what is the cause of prolapse or pelvic floor disorder?
Weakening of pelvic floorness.
Birth trauma, very good, lovely. Who said it? Raise your hand. One chocolate to her. You can collect your chocolate later. Okay? If you want, you can pass it on. Don't eat it in between. So, birth trauma. You have to remember, menopause aggravates the problem. Otherwise, every menopausal or old women will have prolapse. So, prolapse is because of some kind of pelvic floor trauma during childbirth. And childbirth, normal childbirth, it was a vacuum. Vacuum will cause more trauma or less trauma
More
as compared to
normal vagina delivery.
as compared to cesarean.
Less.
More. So if you want to arrange cesarean, vaginal delivery, vacuum delivery, how do you group them in increasing trauma level? Cesarean is pelvic floor trauma, vaginal delivery second, and vacuum and forceps next. Okay, so it causes more expense. Have you all seen 3 Idiots? If those boys who are not understanding what we are talking about, go and watch 3 Idiots. Okay, 3 Idiots. There is a Malayalam version of it. Tamil version. What is? You watch this, then you will understand how traumatic the childbirth can be. Okay. boys are not watching, we are not studying gynecology, what you will do? Okay. Yeah? Okay. So anything else you feel is important? What is the age?
40 years.
40 years. Which age group prolapse is most common?
Elderly.
40 to 60. It can come after childbirth, usually up to 50 years. When the extra menopausal effects also hit, it is more common. But 40 also can be there. Okay, most common 50 to 60 you can say. Then anything else is important? Move on to examination. Anything abnormal in this examination? They have written beautifully, all of you should write this. BMI. What is the important thing about BMI? You certainly know so. So these patients have more chance of getting proteins. Why? Super. I think I should go back to it. If you understand this much, it is done. Okay. So she was a family. Next. Anything abnormal here? Okay. Next.
I will continue with systemic examination. Cardiovascular system, S1, S2 heard, no murmur. Respiratory system, normal vesicular breath sounds were heard. Bilateral chest was clear. Central nervous system, no focal neurological deficit. Spine and musculoskeletal system was normal. Per abdominal examination.
Cardiac incidence is so high in this area, usually cardiac and diabetes. Every second patient we are operating, I think she has one stent, valve replacement, very high. HbA1c 14, normal HbA1c when I used to see 10, what I had seen before coming there, I had seen 10 HbA1c. I used to send the patient back on medication and tell them to come back after 1 or 2 months. Then we'll see how it is. But here, patient was first patient I saw was 10, but that is last. 12.3 they showed me. I said, my God, 12.3 also, it happens HbA1c. Next they got sent to much more than that. Then 13.6, then 14.7. So much HbA1c is high. And those patients, we are operating them. Once upon a time I used to refuse. Now we are operating because everybody is like that. They are doing very well. Now, rheumatic heart disease is also very high. Rheumatic. I don't know how. But normally also in pregnancy, pregnant women are coming. When they are coming for it is not a cardiology present. Primarily they are coming here and then we know that it is. Very, I have not seen this much. All high risk patient, diabetes and prolactinemia that I will discuss with you later. Okay, so understood? What did you understand? The diabetes and cardiac is very high. So if you want to join after finishing your, can you how many of you are going to take OBGS PG? Raise your hands. Very good. Very good. We are with you. Love you. More others, I'll see what you are doing. You are done for exam. Then no one will say. No, I want everybody to join. They are really good people. Okay? Okay, so next, what do you want to do?
Per abdominal examination, patient's consent was taken, abdomen was soft, abdominal obesity was present, there was no palpable mass, hernial orifices were intact, and a suprapubic transverse scar was seen. Gynecological examination, patient's consent was taken, it was done in supine dorsal position with knees semi-flexed, the mass was of size 4 into 2 cm.
Can I ask one question? Before examining this patient, what did you tell the patient? Did you tell her to go in emptying a bladder? No. Very good. So there are in gynecology always we tell them to empty their bladder except for 2 conditions. What are those conditions? Stress urinary incontinence and suspected prolapse, specifically when we are thinking of cystoscopy. Because once you tell the patient to empty the bladder, you will misjudge. Okay? Because there is no urine in the bladder, even if patient coughs under tension not leak because there is no urine. And other thing, there won't be any bulge and there is no content. You will prolapse, you might think it is just first degree cystosine. Okay, so good, you have not told patient and you have that. Okay.
The mass was of size 4 into 2 centimeter. It was longitudinal in shape. Cough impulse was positive, and there was no demonstrable stress urinary incontinence. There was no redness, excoriation, ulceration, and keratinization over the mass. External loss was present outside the introitus. On palpation,
what information? You said that external loss is visible outside the introitus. Does it give you any information?
it's the cervix that has descended.
That is cervix. Means what? In your mind, what you have done now? Grading. You have ruled out some things. What you have ruled out? You are saying differential diagnosis. What differential diagnosis you have ruled out? It is not inverted uterus, inversion of uterus. It is not a colon. It is not a prolapse. Very good. It is not isolated cystosine entries. So there is uterus which is coming out. Okay.
On palpation, there was ample defect present, grade 2 cystosine present.
Do you see any defect in palpation, master? How do you see cystosine? Cystosine? Do we make the diagram? Why? This is always local examination, madam. What examination you see cystosine? What examination? Vaginal examination? Specular. Okay. Cystosine, when you see a mass. Okay. To examine cystosine, what you have to do? You have to retract the posterior compartment and the central compartment, and then tell the patient to cough and that anterior compartment bulges, then it is anterior defect. And you can see cystosine. Okay.
There was a long elongated tubular cervix present. We couldn't get above the swelling, grade 3 uterovaginal prolapse.
What did you want to differentiate when you said that?
The grade 3 and grade 4.
Grade 3 and grade. What is the difference between grade 3 and grade 4?
Grade 4, the whole uterus along the cervix descent. It is outside the introitus.
So fundus is also outside the introitus. So if you can pinch 2 fingers above the mass, that means what you are feeling is just vagina. There is no uterus there. That is called the other name of this kind of older name of this kind of prolapses. Proceed.
On speculum examination, grade 3 uterovaginal prolapse with cervical elongation and grade 2 cystosine was
So
present.
you see how this, it is actually everything is like we have made this diagnosis from the stream, isn't it? We said there was a mass vagina, it was a prolapse, it was a cystosine, and we said that she has no rectal symptoms, so most likely rectal intracephalus posterior compartment was not depicted. That's what we are. So every time history gives you 70% of the diagnosis. Next 20% you get for examination and investigation add on less than 10% to your diagnosis. Okay? So here everything we have found out from the history itself.
For vaginal examination, cervical elongation present, uterus was retroverted and bilateral fornices were free.
What is the importance of seeing bilateral fornices free here? Oh my God, we have done popules. What is the importance? What is the importance of saying that bilateral fornices are free? Or
Any mass.
Huh?
Any mass.
There is no mass and mobilities you will be able to, because she has previous cesarean also. Okay, so if everything, okay, we'll discuss this. So POCU, you know, what is the full form of POCU? I know you know it here. Tell me. Which year it came?
1996.
Oh, super. So this, you were born. Yes, she was not even born. But I'm so happy that they have done this. This is an old system. This is nothing new. Okay? 20, 30, how many years, 20 years. You calculate from her age that she was not born. So the system was there. But it is a very complicated system because of many things. It has its own advantages and disadvantages. But from undergraduate level, if you can tell that something like this exists, and if you can tell what is the full form for me, I am done that moment, but they are great also. What is this? Anything you want to tell about this?
On the anterior vaginal wall, point A was present 1 centimeter above the uterus.
I think I'm just happy you don't tell your story. Very good. So Poplar has a grid like this. Okay. And what is the stage?
Stage 3.
So ultimately if you want, you have to just tell it. That is what PG is basically. The stages. How do you stage? After doing all this calculation and vision, how do you calculate the stage?
The reference
That is a simple formula, you know.
The reference point is the hymen.
Okay, very good. Reference point is the hymen.
1 centimeter above the hymen is stage 1. If the leading point is present 1 centimeter above the hymen, it is taken as stage 1. If the leading point is within 1 centimeter above and below the hymen, it is stage 2. And beyond 1 centimeter below the hymen is stage 3.
Very good. Okay, give them a clap. Very nice. I am the best. And marks after you? You give marks? Next.
Summary of 40 years old lady. Paradigm given to abortion 1 with history of vacuum extraction for her first childbirth came with the complaint of mass setting per vagina from past 4 years, which increases on straining with history of incomplete voiding of bladder and increased urgency. On examination, grade 3 intravaginal prolapse is found associated with grade 2 cystoscopy.
Now my next question is, what will you do with this lady? 40 years old with 3rd degree prolapse. How do you want to manage her?
Ma'am, it is a clinical diagnosis.
Very good. So first thing is, no confirmatory investigation is required. It is a clinical diagnosis. Okay?
But still for further investigations, we can do USG abdomen and pelvis.
USG abdomen by further investigation is screening of abdomen. Because most of these surgeries will be doing from vagina. We will not get a chance to screen the abdomen, and there can be some problems. I think Aman is trying to give you a hint also. Some problems if those are there, they can cause a great prolapse. See. Okay, chronic cough can be there.
Abdominal mass.
Abdominal mass can be there. Or ascites. Okay. So if there history is, your patient had history of what was the duration? 4 years. Or it becomes troublesome for 1 month, that's why she says. But short history very important to do. Her chest, you have to auscultate and evaluate chest as well as. Because I had some patient. Patient was with pessary, I care, and also patient was with pessary for I don't know how many years. Very obese patient, we cannot predict, so nobody thought. Everybody just changed the pessary and sent her back. So then 1 unit was resolved, and when we took the patient came to us by time. She has 28 week size uterus, fibroid. Okay. So that was the mass which was causing cystoscopy and all the complaints. Okay. Then next, so what will you do? Investigations done. Pratik has shown me is what, and we will have given 90 seconds.
Postmortem urine check.
No, leave it. How is your plan? What I do? If you say today I will post, that is not for you. Tell me one line management, ultimation. What are you going to tell patient that I want? This is your treatment.
Surgery.
What's
Vaginal hysterectomy plus anterior colpography.
Very good. I am so happy that you did not say the thing which people say the best clap for you. Deepika wants me to go, you are happy with the answer, I don't know. Okay, so you did not say that, so it is site specific. We have diagnosed cystoscopy, we prepare only cystoscopy. Hysterectomy for your level, PGs can fight for against it or for it. Whether you want to do hysterectomy for a 40-year-old lady, you can say that you will discuss with the patient. And for you, any case of prolapse, if you get an exam, you can say that vaginal hysterectomy will repair whatever is detected. Okay? I think Kate was saying we have more to add because I'm not. Pandey wants to add something. So give them a big hand. Okay? See, later on also in the second half of the day, there are some quiz parts which Pradeep, Monica and Sirisha are going to conduct. I hope you know that Monica and Sirisha are urogynecology fellow. Any other question if you have to discuss with them which you don't understand, which because of limitation of time we can't discuss, please feel free to ask them in the afternoon session. Okay? If any concept now we can ask them the answer. Okay? I told you without your permission.